This is Dr. Sandra Brown talking about the placebo effect, part 2, why clinical trials need a placebo control. And I'll warn you now that this talk is fairly geeky and not open to much snark. But I think it's important that you take your time, stop the slides when you need to look at the numbers, to understand my message about the critical importance of clinical trials that use placebo control. Without them, you know almost nothing. First, what are those words, double-blind, placebo-controlled trial? Basically, you have two treatments in play. One treatment contains the actual drug, along with inactive ingredients. When we talk about an eye drop, we typically talk about the vehicle, because the vehicle is liquid, and the ingredients in the vehicle are supposed to be inactive, which is to say, have no beneficial effect on the disease or condition for which the drug is being tested. And then you also have the placebo. This contains all of those inactive ingredients in the vehicle, but not the drug. Placebo-controlled means that a group of patients with a disease or medical condition is recruited, and these patients are as similar to each other as possible. A certain number are randomly assigned to receive the drug, and a certain number are randomly assigned to receive the placebo, or in the case of an eye drop trial, we would call that the vehicle. This random assignment is not necessarily a 1-to-1 ratio. Typically, you will have more patients in the drug arm than in the placebo arm. What does it mean for a trial to be double-blind? This means that neither the patient nor the doctor knows whether the patient is receiving the drug or the placebo. The bottles are identical in all respects, and they're labeled with a number. Now, somebody knows. It's typically the trial coordinator back at the home office. But you don't know as the patient, and your doctor doesn't know either. Why go through all of these machinations? Placebos can be really powerful, and the only way to keep the placebo effect from influencing your perception or your doctor's perception of benefit is to neutralize this by having a placebo treatment group. If every patient got the drug and knew it, some of them will report benefit due to the placebo effect, not a drug effect. There is a type of trial where the doctor knows what you're getting, which is called a single-blind trial. But this has been proven to influence the nature and detail of their examination's findings and also subtly affect your doctor's interactions with you, the trial patient. So single-blind trials, although better than unblinded trials, still do not have the same robustness as a double-blind trial. Let's take a look at one of those trials where the patient knows what they're getting. In fact, every patient gets the drug. This is called open label. You've got 50 patients who get this drug as part of a study. 25 report that they're better, and 25 report that they're not better. Well, 50% chance of improvement with this drug. Hey, I want it. But let's add a placebo control. We'll do a 1-to-1 randomization. We have 50 placebo patients. And the placebo patients reported that 25 of them got better and 25 did not get better. So this tells us that the drug actually has no benefit. Drug is just as good as placebo, which is to say, it's not any better than placebo. How can this possibly be? Well, some conditions naturally show spontaneous improvement. Bacterial conjunctivitis is one of these. If you don't treat bacterial conjunctivitis at all, it will get better on its own. If you give it an antibiotic, it will get better faster, but not a whole lot faster. But spontaneous natural improvement might be true for pink eye. It's not really true for dry eye, though. So the other possibility is that the placebo is actually not inert. It may have an unanticipated beneficial effect on the disease, in this case, dry eye disease. This brings us once again to the Restasis story. I keep circling back to this because there's so much to learn from it. Restasis is approved for treatment of moderate to severe keratoconjunctivitis sicca. The FDA actually denied approval of the original application in 1999 because Allergan was trying to show symptomatic improvement, and it turned out that there was no difference in symptom scores between Restasis and placebo. In 2003, after, I'm sure, very hard knocking on the doors of the FDA, Allergan managed to get Restasis approved. They had to switch to an objective score, a pretty bad one, which isn't used much anymore, the Schirmer score. as the main drug effect outcome. And if you want to read a very enlightening blog piece about the true effectiveness of Restasis, follow that link below. Why did this happen? Why is it that Restasis was so minimally effective relative to the vehicle? Well, it happened because the inactive ingredients were not inactive at all. They were active. And that really shouldn't have been a surprise to anybody. On the left, we have the active and inactive ingredients for Restasis. On the right, the active and inactive ingredients for Refresh and Dura, which we'll talk about more in the next slide. Follow the red arrows, and you'll see that, with the exception of mannitol in Refresh and Dura, all of the inactive ingredients in Restasis show up on the ingredient list for Refresh and Dura. So basically, it was a great vehicle. That's the message of the original application for approval for Restasis. Refresh and Dura, terrific eye drop. Allergan might be thinking, wow, we did not mean to make that, but they did. Remember, true placebos have no effect on the disease causing your symptoms. The benefit is through the placebo effect only, your belief in benefit. But if you make a vehicle which is not really placebo, it's going to be more difficult for you to show that your drug is effective. I really think that was predictable. Come on, guys. The backstory on the vehicle is that Refresh and Dura contains castor oil. I thought some of you might be interested in the reason why. Cyclosporin does not dissolve in water or saline, and cyclosporin is the active ingredient in Restasis. It turns down inflammation on the ocular surface. So Allergan had to develop a vehicle that would keep the cyclosporin suspended. It's not dissolved, it's suspended, that's why it's milky, and stop it from clumping up uselessly at the bottom of the vial. It also had to spread over the ocular surface and not be super irritating, although many patients did find it at least somewhat irritating. Thus the invention of Refresh and Dura, the not a placebo. And Refresh and Dura was discontinued as an over-the-counter drop in December of 2008. I am pretty sure this is because Endura was cutting into Restasis sales too much because Endura was cheap, Restasis was super expensive. So eye care providers across the land were saying, well, go try the Refresh and Dura first. Let's get back to our geeky tables. Would you approve this drug? We've got 50 placebo patients and 50 drug patients. 10 placebo felt better, 25 drug felt better. So we've got 20% improvement versus 50% improvement. That seems as though the drug is actually substantially more effective than placebo. So I'd consider it. Filling in those blanks, we can say, yes, the drug is better than the placebo. But let's split out that not better category a little bit. Looking at our 50 drug patients, we have 25 better, 10 not better, and 15 worse. Looking at the placebo patients, we have 10 better, 30 not better, and 10 worse. Wait, how can a placebo make you worse? Well, the placebo didn't make them worse. Some of the clinical trial patients just naturally got worse as the trial went along. Both study drug patients and placebo patients can worsen. In the same way that I mentioned earlier that study drug and placebo patients can show spontaneous improvement. The only way to figure out what's spontaneous versus what's drug-related is to have that placebo arm. In this case, do we blame the drug? Maybe these 15 patients just got worse, unrelated to a negative effect of the drug. But when we compare it to the placebo patients, we can see that 50% more drug patients than placebo patients got worse. This would definitely require some exploration to determine whether it was somehow related to the subpopulation of patients who were in the drug arm of the trial, or whether these were truly drug adverse events. Note that, depending on the benefit of the drug and the severity of the adverse events or complications, the drug might still be approved. It's more than just a numbers game. But here's the take-home message. Without a placebo arm, you'll never know how often improvement is due to the drug, not the placebo effect, and how often worsening is due to the drug, not a natural worsening of the condition. How does this connect to regenerative medicine biologic eye drops? None of these drops is FDA approved. None has undergone a double-blind, placebo-controlled clinical trial, which means there's no proof of benefit and no data on adverse events. Stimulize has, to its credit, 15 testimonials, and Regenerize has junk science galore. You might be saying, Dr. B, I am sure my biologic eye drop is working. Well, please consider this. It is possible that you are having a placebo effect from your belief in cytokines, chemokines, and growth factors. To put this belief in context, please see the video Sludge, and don't have faith in junk science. You may have a placebo effect from belief that biologic eye drops are less harmful. They have no preservatives, they're natural and chemical-free. To which I say, don't buy a risky bottle. See the video, Preservative-Free Eye Drops. And it's also possible that the vehicle is actually providing some true therapeutic benefit. In the case of Regenerize, what's really in it? It might very well have glycerin, and glycerin is a well-established, over-the-counter artificial tear supplement. Part 3 coming up. Placebo transference from autologous serum tears to biologic eye drops.